right. Looks like everybody should be able to see. So thank you for that introduction. As Pat said, I am coming to you now from the Virginia Commonwealth University and VCU Health System here in Richmond, Virginia. And this is a big topic, diagnosis and treatment of Alzheimer's disease, vascular dementia, and mixed dementias. And so mixed dementia can cover so many things. So I tried to pick what I thought was going to be the highlights, what people really wanted to hear about the most. I've tried to leave plenty of time at the end so that sometimes the best part of this is the questions that you have that I didn't think to address. So please feel free to ask those here at the end. As I'm getting started, I just want to make everybody aware that, as Pat said, I'm a part-time VA employee, and my views do not represent those of the Veterans Health Administration, the Department of Defense, or the United States government. Thank goodness. I have some funding from the Alzheimer's Association, Dementia Alliance of North Carolina, and NIH, and I also do some mostly continuing medical education type work in the Alzheimer's disease and related dementia space. So we're going to talk through sort of broadly some common language that we use, including what do I mean? What do doctors mean when they say MCI and dementia? And then talk about some of the specific etiologies, and then treatments for Alzheimer's disease, vascular dementia, more broadly, mixed dementias. And then I've also, one big update from when we had this last time. So there were no fully approved disease-modifying therapies for Alzheimer's disease in 2022, which is the last time I gave this talk. Now there are. And so the treatment space in Alzheimer's disease has changed quite a bit, just in terms of the things people are asking about and need to be aware of to make fully informed decisions. So I'm going to try to briefly cover the monoclonal antibody therapies. These are the infusion therapies for Alzheimer's disease, lecanemab and donanemab. So before we get started with the causes, we need to talk about cognitive syndromes. When we talk about changes in memory and thinking that are acquired or occur later in life after normal development, we've got to contrast that against normal aging. And I've got bad news for anybody after the age of 25, which includes myself. There is a downward trajectory in many of our cognitive functions. And that's not a surprise to anybody who's gone through it. Certainly not a surprise for me, because I've experienced it. You can't compare yourself to how you were when you were 25 years old or 35 years old, because we've all changed relative to ourselves. So normal aging, we experience changes in many of what's referred to as our fluid cognitive abilities. The things that tend to actually get better or stay the same are the so-called crystallized intelligence. One way to think about that is just sort of the wisdom and accumulated knowledge of the world. I think most of us would agree that that has been something that has likely gotten better and not worse as we've gotten older and acquired more of it. When there is a decline from normal aging, and this isn't just like you think it's worse, this is a measurable change in your memory or your language or other forms of thinking and cognition. If it's measurable and objective, but you're doing all your day-to-day tasks just fine or essentially normal day-to-day tasks, that's when we use the term mild cognitive impairment. Now, one of the things that I tell my trainees and my patients all the time is that mild cognitive impairment and dementia are not diagnoses. They are descriptions, right? So it's sort of like saying your arm is weak or your arm is weak and you can't use it well. That's a great thing to know, but if that's where the physician stopped in telling you, you'd be a little perturbed at that description of your arm. And I think that we owe our patients a bit more than that for the description of why they've had changes in their memory and thinking. And so keep in mind that mild cognitive impairment and dementia are really just descriptive terms that mean exactly what I'm showing you.
Pieces of toast and some scrambled
And
eggs.
so
My toast is in the freezer. I think that, oh, it's in little. No. Sorry. Oh, goodness.
nope. All right, I'm unmuted now. So I think, can somebody give me a thumbs up if y'all can hear me? Good. Okay. So if you have mild cognitive impairment, I'm going to try to go back here. Mild cognitive impairment, because it doesn't tell you what's causing it, in some individuals that gets better. And so this might be somebody who's got these cognitive changes, but it's really related to their untreated depression or their untreated sleep problems or things that might be modifiable or fixable. In other people, that mild cognitive impairment stays stable. Sometimes we don't identify the cause of what's leading to these changes, but we don't see it getting worse over time. It may not get better despite our best efforts. But again, mild cognitive impairment, a description, not an etiology. And then there's dementia. And dementia, the most common question that patients ask me is, well, wait a minute, somebody told me I had dementia. How is that different than Alzheimer's disease? Or somebody told me I had Alzheimer's disease. How is that different than dementia? And the thing to remember is that dementia is a description. It's a big umbrella term that describes somebody who's got cognitive complaints with objective impairment, and it causes difficulty in performance of their day-to-day activities. At the very mildest stages, it's the instrumental daily activities that are impacted. This is things that you got to do to live independently: drive, cook, clean, manage your finances. At the moderate stages of dementia, these are basic daily activities, and these are the things that you need to do to be able to sort of provide your own self-care, being able to dress yourself, perform your own personal hygiene activities like bathing and going to the bathroom. And then finally, severe dementia is when someone is fully and totally dependent on another for all of their care. Now, you'll notice here that dementia, in most instances, in all neurodegenerative causes of dementia, everyone who ends up at a stage of dementia went through a stage of mild cognitive impairment. It may not have been recognized. We estimate that about 80% of people living with mild cognitive impairment probably don't really recognize that they have it. They don't come to the attention of any doctors because it's something that we pick up on tests, but if it's not causing you to have trouble in your day-to-day life, it may not be something that you would even note when you go to the doctor. That said, not every person with mild cognitive impairment, by definition, goes on to develop dementia. It depends on the cause. If somebody has mild cognitive impairment due to Alzheimer's disease, then provided there's enough time, that person will develop dementia. But if they have mild cognitive impairment, maybe due to poor sleep or a stroke, and they don't have any more strokes, they may not go on to develop dementia. When we think about treatments, and we're going to talk a lot about treatments over the next hour, so there are some things that have no effect. Even some things that I try don't really have an impact on someone, their function or a symptom that they're having. What we'd love to do for the disease is slow the progression down. Maybe we have some treatments that are able to do that now in Alzheimer's disease. The magnitude of slowing, I think, over time is still going to be a big topic of concern. Of course, we'd love to completely arrest and stop the disease from getting worse. We're certainly not there. at this point. We'd love to be able to do that. We'd love to be able to improve things. I think that is a much, much harder ask because especially at the point that somebody has developed symptoms, and those symptoms are due to brain cells having died and degenerated, and just getting those back is a much harder task even than stopping a disease. And we're not even to the point to where we can totally stop the disease when symptoms are present. Now, much of what we do is a symptomatic treatment. This would be a good example of this would be donepezil or Aricept. There is some benefit to that treatment in people, and whatever that benefit is, you're going to get it, and then you're going to continue to see the same rate of decline going forward because it doesn't really impact the underlying disease. Now, that doesn't mean that it's worthless. That's still a beneficial thing for many people, depending on the magnitude, because whatever, you can sort of look at the triangle there and see that you've led to some prolongation of functional independence. The estimates from a lot of the early cholinesterase inhibitor trials, like Aricept or donepezil, maybe 6 months to a year of prolonged function, which is something, but it's certainly not where we want to be. We want more than that. And so that's sort of the amount of time that function would be prolonged. Now, moving along to the causes of dementia that we're going to talk about today, this is a well-known picture from the Alzheimer's Association that describes this idea of dementia being an umbrella term, and then shows these other causes up under it. We're going to focus on the two most prevalent: Alzheimer's disease, the most common neurodegenerative dementia, and vascular disease, which is not strictly speaking degenerative, as the second most common cause. But we're going to touch a little bit on things like Lewy body dementia and even something that's not listed on here, I think because it's just been poorly recognized and diagnosed, and that's something called late that we'll talk a bit about and how that interfaces with Alzheimer's disease. Now, the real world view, we like to pretend that these are nice, discrete categories, and we can just say, well, this person they clearly have Alzheimer's disease. This person clearly has vascular disease, and but for that disease, they wouldn't have problems. And the reality is things are messy. And the presence of these pathologies in the brain often overlaps. And we'll see a little bit more about that. This is a well-known study from 2007. The Rush University group, which is up in Chicago, has done a tremendous amount of community-based work and really getting a good cross-sectional sample and longitudinal sample of people living in the community with dementia. And one of the things that they do better than almost anybody is follow people through to autopsy. And autopsy is a really important snapshot of what was present in someone's brain at the time that they died. And what they found is that most community-dwelling older people had brain pathology, whether or not they had dementia. Those with dementia often have multiple brain pathologies and more of it. And so another way to say that is that, when a brain autopsy is done, there are multiple brain pathologies present that likely contributed to a person's symptoms. Now, it's not a 50-50 split. So when we say somebody has mixed dementia related to Alzheimer's disease and vascular disease, we're not saying that they were both carrying the same weight of symptoms. We're saying they're both there and probably contributed. It's often possible to say that there was a particular, maybe it was Alzheimer's disease that was the primary pathology, and there was contributions from the vascular disease, for instance. The most common pathologies seen just by the numbers were Alzheimer's disease and vascular changes in the brain causing vascular dementia. But there were others that were not uncommon at all. Um, when I think about making a diagnosis, so this is me trying to provide a little bit of an insight into how I think through somebody who's sitting in front of me and try to help them understand what's wrong. This first step that I have is there something wrong in the brain? And anytime someone's sitting in my office, there's something wrong. I mean, they're worried, they're concerned, they've noticed something. And so when I say, is there something potentially wrong, what I mean is there a disease process that I need to be worried about? And has their memory declined beyond normal aging? Very common for folks to come in for an evaluation, and at the end of it, my assessment might be actually things look pretty good right now. You're noticing some changes in your memory, but I'm not worried about your brain health at this time. When that happens, my goal is to try not to be dismissive because, again, that person came in for a reason. They were concerned, they were worried, and to talk to them about what I'm seeing, why I'm arriving at that conclusion. And then I try to shift the conversation a little bit to what sometimes referred to as brain health, a brain health focus. What can they do to help ensure that they don't have a problem in the future? And so we will talk about the things that have good evidence for helping to promote brain health and resiliency to cognitive decline. And we also talk about things that don't have good evidence or data to support it, but that sometimes people are perhaps marketed to buy. So the options here are, does this person have what we refer to as subjective cognitive decline? Do they have mild cognitive impairment, or do they have dementia? That's the first decision that I'm making. And then when I make that decision, I'm also asking, well, what does it look like? What is it about their memory and thinking and cognition that's wrong? It's often the case that people come in and they say, Doc, something's wrong with my memory. And I will test them, or my colleagues in neuropsychology will test them and realize, yeah, it feels like memory, but it's actually not memory. It's more of an attention or executive function problem, or maybe it's actually a language problem. Many things feel like a memory problem when it presents in one's day-to-day life. But when we do the testing, we're trying to better describe what cognitive operations they really have a problem with. And you can think about this similar to if you go into the doctor and you say your arm is weak, well, okay, that's good, but where is it? What muscles are weak? Is it a problem in the joint? Is it a problem in the muscle? So we have to figure out where the problem is and better describe it, because that helps tell us what could potentially be wrong. And so I may decide that somebody has predominant memory loss or language changes or what have you. And from that, we can get to a memory predominant mild cognitive impairment or a mild dementia that's primarily a memory problem. And we still don't have the cause or the etiology. I've just got a really good description. And so then we move along to what's the cause. And this is where I start to look for evidence of a brain-based disease or the like. Alzheimer's disease, Lewy body disease, frontotemporal dementia, vascular dementia, all of these are potential causes. But it is common for people to have who have a degenerative disease to maybe also have non-degenerative problems that are contributing to those symptoms. So what do I mean by that? Well, Alzheimer's disease and moderately severe depression. Certainly few people would accuse depression of helping one's memory. And so if you've got both of these things, it won't fix all of the problems. It won't lead to the resolution of Alzheimer's disease. But if I've got somebody who's suffering from Alzheimer's disease and moderately severe depression, if we can treat that depression, their day-to-day experience of their memory and their quality of life may substantially improve. I may have somebody who has vascular dementia and severe untreated sleep apnea. Well, if I can get that sleep apnea treated, maybe their dementia doesn't seem as bad as it did because some amount of problems they were having was being carried by that sleep apnea. And so part of what I'm trying to do is come up with a bit of a formulation for what all is contributing to that person sitting in front of me and what can I do to help them. Now, I'm going to move a bit to talking about how we diagnose these different conditions now. And I'm trying to toe the line between going into too much detail and not enough. Alzheimer's disease has changed dramatically in the past decade. And it's more recently been thrust into the more clinical side of things, where it used to be predominantly research. We know that in the clinic, when I diagnose Alzheimer's disease, I'm really only diagnosing this in people who have symptoms, because as I told you, the first thing I'm doing is determining whether they have that objective cognitive decline. And so the diagnoses that I make are mild cognitive impairment or dementia due to Alzheimer's disease. Because that's when people come in usually, and that's when it's considered appropriate to obtain those biomarkers. However, we do know that the changes in the brain of Alzheimer's disease begin years and decades sometimes before clinical symptoms. So that's where this somewhat, depending on who you talk to, controversial construct of preclinical Alzheimer's disease emerges. And this is something that I have dealt with a lot in a research space, where we might see people who are completely healthy. They come into a research study and we obtain biomarkers for Alzheimer's disease and find that despite them being totally cognitively normal on testing, very detailed testing, they do have these biomarkers present in their brain. And what we know then is that their risk for developing symptoms in the future is higher than if they didn't have those biomarkers present in the brain. So why is that? Why do why do these things happen, and what do they tell us? And why is this even more relevant today? Well, it's more relevant today because in the past, you had to see someone like me, or you had to go to a research center for that question to even be a potential to ask. You had to get cerebrospinal fluid, and very few people are lining up to have lumbar punctures done for the fun of it. Or you had to get very expensive PET imaging that wouldn't be covered, and you would be charged some exorbitant price of $20,000 because it wasn't covered by insurance to have done. So nobody really got that done unless it was pretty appropriate. Well, more recently, blood-based biomarkers have been marketed, and they're good biomarkers. Many of them are quite good at answering a question: are there changes of Alzheimer's disease in the brain? What they cannot do is tell you whether you have an observable, measurable clinical problem due to those biomarkers. All right. And so I just want to spend a moment on this graph here. And it looks a little complicated, but I'm going to try to show you why this matters for things that you could actually be confronted with, out in the real world. So this very first line back here past -17 is amyloid beta 42. So 17 years on average before people have clinical symptoms, before they would be eligible for a diagnosis, their amyloid beta becomes abnormal. 17 years, right? So you can measure some of these biomarkers as abnormal years or even a decade before they would ever be a problem, right? Um, it's only as you get further and further down here, so you're going down all the way this green line 8 years before is the MRI. So you can even see MRI changes quite a while before clinical symptoms. And then finally, you can start to measure some very mild clinical changes in those years preceding a diagnosis. So you've got a very long lead time with these biomarkers before they've caused clinical symptoms. And this comes up quite a bit now because you can go into any LabCorp, you can go into any Quest diagnostics, and somebody can order one of these blood tests. So I can, some examples of where this has been a real problem is, we'll get a referral for somebody who maybe, let's say they're 78, 80 years old, and they go to their doctor and they say, I'm really worried about my memory. I'm worried about my memory. My mom had dementia, and I'm just concerned that I'm going to develop Alzheimer's disease. And very well meaning, someone decides, oh, sure, I'll order this blood-based biomarker, and sure enough, it's positive, right? That person, and the person who's ordered it probably doesn't really have the information to contextualize what that means. So now this person is terrified that their life is over. And they may take 9 months before they're able to get in to see someone like me, where I'm able to tell them, yeah, that biomarker is positive, but if we take 10 of your friends who are totally normal at your age, 4 of them are going to have positive biomarkers, and many of you are never going to have clinical symptoms related to that. So yes, you're at increased risk, but it's often not the way that they have in mind that it is, this immediate problem. Now, that's if somebody's totally normal. And so I worry about the Pandora's box that is open by these types of biomarkers. I use them in practice. I think that the emergence of these new drugs, which has forced people to think about what the cause of dementia is why we're seeing so many of these biomarkers ordered. But just so that people are aware, a lot of times when they're ordered without the clinical expertise, the results can potentially be a little bit confusing. And so ordering a blood-based biomarker without a clinical assessment and determining that someone has an objective clinical diagnosis at that time isn't really appropriate. And it would go against every published appropriate use criteria at this time. So it's if I see somebody and they say, well, look, I just want to know, okay, can't you order it? The answer for me is no, I can't and I won't, because I don't think it's an appropriate thing to do. And I'll spend time talking about why, et cetera, but it's not something that I would be willing to do in clinical practice. Research setting is a different thing. I'm happy to refer them along to research trials that might offer this information, as well as potential interventions for that information. Now, when we talk about things like memory loss and cognitive syndromes, one of the things that people say is, okay, well, they've got memory, there's memory loss and they have dementia, so that's got to be Alzheimer's disease, right? Well, it doesn't. And so I want to introduce a concept of a diagnosis that's been around for a while, but has very poor recognition among many practicing neurologists and physicians. And certainly, I think most people just haven't heard of it. So what this is showing here, if you just look at, I mean, you can see both of them have roughly the same color breakdown, but this one over here, the ADNI, is a little easier to understand. So this blue piece here is Alzheimer's disease, and these are people that came in with memory-related dementia. So these folks in blue here, about 30% of them had nothing but Alzheimer's disease as the cause. Okay. These folks here had Alzheimer's disease, but they also had this other thing called late, LATE. And we're going to talk about that in a second. And then these folks here who had a memory predominant dementia, well, they had Alzheimer's disease and Lewy body dementia present in their brain. All right. So all of these folks down here had some form of Alzheimer's disease or Alzheimer's disease with something else. But then up here, total about 25%, well, they had no Alzheimer's disease at all. And they had a clinical presentation that many people have historically and routinely called Alzheimer's disease based on just the clinical presentation. And that includes this entity here called late. There's another one here that we're not going to talk about because it's even less well known, called part. And then Lewy body dementia, believe it or not, rarely does present mimicking an Alzheimer's disease presentation with memory predominance. Not the most common presentation of it by far, but it can do it. Now, this late here is something called limbic predominant age-related TDP 43 encephalopathy, hence why we call it late, because that's quite a mouthful. And this is something that is becoming more and more relevant and discussed precisely because biomarkers are becoming more widespread. This is typically in older adults. It's the diagnostic criteria say 75, but really it becomes even more prevalent above the age of 85. It's got a slower course than Alzheimer's disease, but it looks a lot like it. It's got predominantly memory, usually spares the other stuff. It causes the same brain changes or similar brain changes to what you'd see in Alzheimer's disease. And as I just showed you, it can kind of occur with or without Alzheimer's disease. But this will be where I see a lot of this is somebody will go to the doctor, they'll be concerned for Alzheimer's disease, and now their doctors who have access to these biomarkers will do that evaluation and go, well, they look like they have Alzheimer's disease, but they don't have the biomarkers of Alzheimer's disease. So what is this? And this is a fairly common clinical scenario that I see where someone looks like they may have Alzheimer's disease, but they don't have the biomarkers for it, and it can be this entity here. This is a very common co-occurring pathology in our older adults with dementia. And so we see this much more frequently as we get into the 80s and 90s. Vascular dementia is, depending on where you're at in the health system, is either dramatically overdiagnosed or underdiagnosed. So it really depends on the changes we see in the brain. Risk factors alone cannot tell you if somebody has vascular dementia. You could have every known risk factor, hypertension, sleep apnea, poorly controlled diabetes, you name it, high cholesterol, smoker, every one of those things. And if you don't have brain changes related to the vascular injury, you just can't diagnose vascular dementia because what has to occur is an injury to the brain from the vascular disease. This can occur through either a single big stroke, or it can occur if somebody's had a subarachnoid hemorrhage or other type of bleeding in the brain, but it can also occur just to what's called small vessel disease or white matter hyperintensities. This used to be called hardening of the arteries decades ago. And so what you're seeing here is these little white spots. So when the doctor or the radiologist talks about these white spots on the brain, this is what they're talking about. And it's really got to be more substantial before we can think that that's what the cause of someone's cognitive impairment is. Now, you can have different degrees of these diseases. And on each end, you've got people who have a pure cause of their impairment. Some people have one well-placed stroke, no degenerative pathology. They have pure vascular dementia. Some people have no evidence of vascular disease, or they only have one pathology in their brain, and they might have a pure neurodegenerative dementia. But many people have a mixed picture of the dementia. So why does any of this matter? One of the biggest things that I have to I think, combat in medical circles is that it matters to tell somebody what's going on, more than just telling folks that they have dementia and being done there. Why does it matter? Well, I think it should go without saying, but I don't think it can go without saying. Some people just want to know why they or the person they love is having decline. And I don't think you have to justify that any more than wanting to know what's happening to somebody that you love or what's happening to yourself. So I think understanding that is cause enough. Not everybody will care. And so some people will hear, well, it could be one disease or the other. They are both progressive. They may not want to know, or they may not care so much about differentiating between the two. I respect that, and I don't do these workups in everybody, but I do talk about it. Treatments can differ in subtle but important ways. So some of the things that we'll talk about shortly, the Aricept donepezil is much more effective in Lewy body disease than in Alzheimer's disease, and it's ineffective, or at the worst harmful, in frontotemporal dementia. You've got to be very cautious with antipsychotics in Lewy body dementias. We use them, but we use a much more limited and restricted set. And it is helpful to know the people in whom I really have to avoid some of those drugs in. Prognosis differs. So if somebody comes to me and they have late and they do not have Alzheimer's disease, I can tell them within reason that it's likely their course is going to be a lot more indolent and slow and less likely to reach the more moderate and severe stages of dementia. And then finally, I put this last, but it's honestly the first reason that people are doing more of this work now is because of these disease-modifying therapies for Alzheimer's disease. To be able to offer those treatments, you got to know whether that's the cause or not. So that's driven a lot of the changes in our practice. So when we talk about treating cognitive symptoms, and I'm not going to go I'm not going to go disease by disease. I'm going to talk about different symptoms and discuss where it matters in the disease, because the treatments overlap. For cognitive symptoms, cholinesterase inhibitors are FDA approved for Alzheimer's disease. They are approved in Japan for dementia with Lewy bodies, and I think they work and have a bigger effect in dementia with Lewy bodies. The best case scenario that we get with this drug is that it's going to improve symptoms, and it depends on whether it's Alzheimer's disease or Lewy body, what we're likely to improve, and prolong independence. But there's going to be no change to the disease course underneath it all. So the disease will continue to get worse with or without this treatment, but it can provide symptomatic benefit. It has some side effects and some reasons that people can't or shouldn't be on the drug. It can cause heart rate problems, slow heart rate. So sometimes we have to get an EKG first. It can cause stomach upset and nausea and diarrhea, increased urination, some salivation problems, runny nose. And sometimes the stomach upset, we can get around it by going up really slowly. Other times we can't. And the answer is you just can't be on this class of drugs. You feel too bad. So I usually tell patients and families that if you feel worse for whatever reason on the drug that I'm giving you, let me know. We probably should stop it. The evidence is mixed if it's predominantly vascular disease, but I do give an empiric trial. And I think the evidence is the trials are smaller, but the effect is larger in Lewy body dementias. And the few times that I've had just really remarkable results in fixing someone's hallucinations or psychosis or delusions, it's really been in somebody who has DLB in whom I get on a cholinesterase inhibitor. Mixed pathology here, I may have somebody who I thought had Alzheimer's disease, but they start to show some signs that maybe underneath this they have the presence of both Alzheimer's disease and Lewy body disease. That may prompt me to more aggressively try a cholinesterase inhibitor or push it to higher doses. We already know that 50% of people who have an Alzheimer's disease presentation and Alzheimer's disease pathology in their brain will also have Lewy body disease present in their brain at lower amounts, and vice versa. It's actually the rarity that somebody solely has Lewy body disease without also having some Alzheimer's disease present in their brain. And so, like I said, that might influence how I would choose medications. If I strongly thought somebody had Lewy body disease as a comorbid pathology, I may just avoid certain medications, and that would be a bad idea in Lewy body dementias. Proving the pathology would maybe open me up to using more medications. Sometimes proving the pathology isn't worth it to the families or the patients, and we just act like that co-pathology is present, and I moderate and change my prescription treatment practices because of it. Memantine is another treatment for cognitive symptoms. The data is not great with memantine, but anecdotally, you can see some surprising results sometimes. So the evidence in Lewy body dementia is not as widespread, but there's an ongoing trial. It's low risk, and yeah, I know some patients have had really very beneficial results and with fairly low side effect risk. So I often will use this in both Alzheimer's disease, vascular dementia, and Lewy body disease. There's pretty compelling data that it does not do anything in frontotemporal dementia. So if I really have clear evidence and confirmation of Lewy body dementia, I usually will not start this medication. Vascular risk is something that we spend a lot of time thinking about in vascular dementia, but also in Alzheimer's disease and Lewy body disease, because vascular disease, as it progresses, will certainly worsen an already existing neurodegenerative disease. So if somebody is supposed to be on an aspirin because of stroke risk, we will give them aspirin, treat their cholesterol. Sometimes they might be on both aspirin and Plavix if they've recently had a stroke for a short period of time. If people have atrial fibrillation, anticoagulation may be recommended depending on the risk factors otherwise. Treating high blood pressure, there's really good evidence that treating high blood pressure helps to prevent cognitive decline in older adults. And so that's one that I do spend a lot of time counseling on. And then management of diabetes, not smoking, treating sleep apnea, all of that can reduce people's risk of further vascular injury. Neuropsychiatric symptoms are probably what I spend the vast majority of my management time doing, because these are the most actionable symptoms often. Not all behaviors need to be treated. Not everything's harmful. They may be infrequent. If something is infrequent, then the risks and side effects of the medicine may not be worth it. Sometimes people can be easily redirected and it doesn't cause any distress. Well, if that's the case, you really don't have to treat it just because it's a symptom. And medications may not be effective. So, for instance, if somebody's aggressive, um, some things are responsive and other things are not responsive to medication. If somebody's in pain or they're experiencing psychosis or depression, and that's contributing to a verbal aggression, we can do something about that. But if it's because they have unmet care needs or they're bored or they're feeling overstimulated or powerless, those may not respond particularly well to medications, and we may not be able to do much about that with meds. First things first, when somebody has any behavioral symptoms, is determining safety. Some things we got to treat. So I have caregivers that will come in and say, "Look, he's trying to hit me, or she's trying to hit me." That probably has to be treated a lot more aggressively and quicker than if somebody's yelling a little bit. And so we have to determine how rapidly we need effect. Um, I always consider physical causes. When changes are sudden and out of nowhere, maybe they seem more confused, I'm going to be worried about an infection or urinary retention or some physical cause that's leading to a delirium or behavior change. Sleep is often a bellwether. So if people are not sleeping well, everything is going worse. And so we may try to target sleep. Um, I look at medications to stop before medications to begin. So, Benadryl, NyQuil, anything with PM in the title can absolutely worsen behavior in dementias. Benzodiazepines are sedating and can sometimes lead to it can make people more impulsive and they can get a paradoxical agitation. Oxybutylene, used all the time for urinary incontinence, can really cause behavioral problems. And the list goes on here. So I will look to see, were any of these things recently added? Have they been on them for a while and maybe the dose was increased? That might be the first place to begin with behavior changes. That being said, we often do have to use new medications to treat these symptoms that you're seeing here along the right. And so when we look at things like SSRIs, they do a lot of heavy lifting for us in the clinic because they have beneficial effects across a number of these neuropsychiatric symptoms. So agitation, they have some efficacy for. Now, I don't start here if it's really severe or it's really dangerous because they take longer to work, but they can be effective for agitation, for depression, obviously, for anxiety, and then finally for apathy, but mostly with the class of these that tend to be a little more increasing energy and a little more activating. And so we might use something like a bupropion or a venlafaxine to target somebody who had apathy. And apathy is just, it's a demotivational syndrome. People just can't seem to really get engaged or want to engage in their activities or hobbies or tasks. Antipsychotics. Now, every antipsychotic has a black box warning in dementia. It increases the risk of cardiovascular events and death. And it is true. There is no way around it. There's no way to pretend that it's just because you're giving it to people that have more severe disease. They do seem to increase the risk of death. My conversation with my patients about this is that we are engaging in a form of palliative care. And these are symptoms that are distressing. They are harmful potentially to people. And so if we can reduce distress and improve quality of life, those risks may be acceptable, or they may not be, but the risk is certainly there. In people with Lewy body dementia, they're sensitive to antipsychotics. And so the ones that are really available to you and easy to use are quetiapine or Seroquel. And if somebody has Parkinson's disease dementia, they may qualify for treatment with pimavanserin, but it's very expensive if insurance does not cover it. We can try to treat psychosis with these, so hallucinations and delusions. Much of the time, what we end up doing is treating the agitation and the aggression that occurs secondary to the psychosis. It is more common for me to treat somebody and make them less agitated while they remain somewhat psychotic with the hallucinations or delusions than to totally resolve the psychosis. And that it's just a very challenging symptom to totally resolve. That being said, I think that the reduction of agitation can be very meaningful for some patients and caregivers. We don't really use this for anxiety. They have an anxiolytic effect, but that's more secondary to when you're dealing with somebody who has um, somebody who has anxiety with their agitation. Now, our cholinesterase inhibitors, and sorry, give me 1 second, y'all. My computer is telling me that it is not charging and it has a low battery, and that's not going to be good if that happens. All right, I fixed it. So cholinesterase inhibitors, these are your donepezil, rivastigmine, galantamine. They are really, really effective for psychosis in Lewy body disease, and I avoid them in frontotemporal dementia. Along with depression, with an SSRI, it may help with depression in Alzheimer's disease or Lewy body dementia. And then you can sometimes see some beneficial effects in apathy, to where patients, caregivers will tell me that their loved one is more engaged with the world around them when they're taking these drugs. Trazodone and mirtazapine are going to be two of the drugs that you hear first for insomnia or trouble sleeping. They're old antidepressants that are quite sedating and are often used for that rather than depression. Melatonin we use for circadian rhythm disorders, so people who need to sort of move their sleep onset time a bit. Melatonin can be helpful for that, and we use it for REM sleep behavior disorder in Lewy body dementias. Often at higher doses. In most folks, if they're just taking melatonin to try to help promote sleep, will take like 500 micrograms, a milligram or two. And here the goal dose is 12 to 18 milligrams, so much higher doses than you would usually take for just sleep. Namenda, as I said, it has been found to have mixed evidence of maybe reducing the global neuropsychiatric symptom burden. And the patients that I've seen it have a really beneficial effect in are probably doing a lot of the heavy lifting in that data. And then there are folks that it probably does absolutely nothing for. But because it's relatively well tolerated, I do tend to try it. Benzodiazepines, now we're getting into things that have potential problems. Insomnia and REM sleep behavior disorder, especially clonazepam, is beneficial in REM behavior disorder. Benzodiazepines are a tool and they have a place, but they have real problems with oversedation, increasing falls, increasing the risk of pneumonia. I've had patients for whom the only thing that kept them from being absolutely inconsolably anxious for the last years of their life was a dose of a benzodiazepine. And so we use it with the understanding that we are increasing the risk of certain things. But if their day-to-day life is better, it may be an appropriate decision to make after talking with family. Stimulants, things like Ritalin and Provigil, in particular, can be helpful when there's depression that's not responding to an SSRI. It has evidence for treating apathy and Alzheimer's disease. And then in Lewy body dementia specifically, the severe daytime somnolence with no other cause can sometimes respond to a stimulant and can be very important to treat. Stimulants are not something that every neurologist is comfortable with. I am, many behavioral neurologists are, but some folks are just not comfortable with stimulants. Psychiatrists use them a lot more in their day-to-day practice than most typical neurologists. So the last thing we're going to talk about is these disease-modifying therapies, because every time I talk lately, I get questions about these because folks want to know, what are they? Do they work? What should we know about them? So I'm going to try to give you a pretty brief overview of them. So there's two, lecanemab and donanemab. They were approved in 2023 and 2024, respectively. They are both really effective at removing amyloid from the brain. No question about that. They do that very well. In carefully selected populations, it seems that slows modestly the decline in Alzheimer's disease. And so you can see over here, the top one is from lecanemab and the bottom is from donanemab. And the lines diverge. There's some signal that the divergence is widening modestly. And so this top one up here is on something called the clinical dementia rating sum of boxes. And it's about a half a point different over the course of a year and a half. And if all we ever get out of treatment is that half a point, these are very expensive and risky drugs that are probably not going to be worth it for many people if that's all that ever happens. What we think is going to happen, and we're hoping that the post-marketing data continues to support this, is that there is a continued benefit and widening from really modifying the underlying disease, so that half a point becomes 1 point, becomes 3 points, and over the course of a 10 to 15-year disease may substantially slow the progress of the disease. There are risks. They are associated with brain swelling and brain bleeding. And both of those, you don't have to be a neurologist to know, are pretty scary sounding things. And so they come with risks. They're not for everybody. There are things that increase your risk of those side effects that are important to know and are what I spend my time determining when somebody comes into me for an evaluation for appropriateness of therapies there. What that looks like is, you can see here these little white areas and a little streak there, and then these little black dots. So this is swelling. These black dots are what's called microhemorrhages. And this is ARIA, amyloid-related imaging abnormalities. It causes edema or swelling, hemorrhage or bleeding. And certain things increase the likelihood of this. So there's a genotype that is an Alzheimer's gene called ApoE4. And if you have 2 copies of that, your risk is much, much higher. Older age seems to be associated with a higher risk of this. Earlier in treatment, so most of this happens right when people are starting therapy, not a year in. And then certain MRI findings, and that's why we have to get an MRI before we use these drugs. The total risk of ARIA, the bleeding or the swelling, in lecanemab, it was about 13%. The total risk of the bleeding type, the ARIA-H, was 17%. You can see it was higher in the original donanemab trial, but there was a modification to that seemed to reduce it pretty substantially. So that ARIA-E risk went down from 24 to 14%. And it had an even bigger effect in the folks who had that bad version of the ApoE gene. And then symptomatic ARIA was reduced from 4.8 to 2.8% in the donanemab trial. And so that gets it a little closer to what lecanemab showed. The overwhelming majority of people do not have symptoms with this. We only find it because we do surveillance MRIs. Somewhere on the order of 3 to 6% of people get symptoms. And when they get symptoms, it's usually things like confusion, headache, dizziness, balance problems. But rarely, but not zero, there's something called severe ARIA, and that can lead to severe uncontrollable seizures. It can lead to an ICU admission, and it can even lead to death. And so there are these big risks associated with these drugs that vary by what uh, what stage of the disease someone is in, what comorbidities they have. And so the people that are potential candidates for these drugs, there's a sort of a narrow list of things that have to be true. They have to have mild cognitive impairment or a pretty mild dementia due to Alzheimer's disease. A very common consult that we get is a referral for treatment because people, their doctors may think, great, we finally have something to offer that could treat the disease, so I'm going to refer all my patients. Many people, the disease has progressed to a point to where it just is not going to be a helpful therapy. And we know that because we've tried these therapies in more advanced dementia and it simply doesn't work. And you also expose people to those risks. And that's why the bedside screening exam, these MOCAs or mini mental state exams, have to be within a particular range. And if people's scores fall outside of that range, not only are they less likely to benefit, um, insurance just won't pay outside of that. And these therapies are quite expensive. The cost of the infusion alone without insurance is probably $27,000 a year. And so it's just unaffordable, but also it's not going to be beneficial based on all of the data that we have beyond a certain point. People's MRIs cannot have certain findings. If they do, we know the risk of ARIA, those bleeding or swelling risk side effects, are just higher. And when they are higher, the risk benefit considerations have shifted, and we can't offer it, shouldn't offer it. People can't. This varies a little bit by location. Generally, people cannot be on blood thinners, things like Xarelto or warfarin, because of concerns about the risk of bleeding. And finally, people have to be able to get an MRI. If there's any reason, doesn't matter what, that people can't get an MRI, they cannot receive these therapies because MRI is the way that we determine whether it's safe to continue giving the therapies. So these are sort of a very just high level exclusion or inclusion list that we look for when people are considering whether they might want to receive these types of therapies. I have this conversation with people all the time, and I think I try to have the same conversation with everybody. And what I see is that I can have the same conversation and I can talk to two different people and they will sort of break on different sides of that conversation. And I'll tell the same thing to one person and their caregiver, and they'll say, gosh, this sounds, let's do it. Why wouldn't you do this? And then I'll talk to somebody else and they'll go, why would anyone do that? And so I think that patient preference, values, uh, belief about what kind of care they want really play a lot into whether this is something that they want to pursue. And my job and my goal is to provide my best understanding of the evidence for the therapies and to help people make the right decisions for them. So I have patients that hear about it and want to do it, and I'm comfortable offering the therapy. And then I have people that hear about it, don't want it. And I'm also very comfortable continuing to care for them without receiving that therapy and respecting that decision that they have. Okay, I think that, yes, that is it. So I've left us with some time for questions, about 10 minutes, and I'm happy to try to answer anything that's come up. I will stop sharing